Good evening, everyone, and welcome to this first webinar by CritiLearn. And thank you to Dr. Bharat Jagyasi for helping us prepare this. So, our topic for today is when ventilator and the patient disagree. So, we are going to talk about how asynchrony can play a role in the ICU, about delaying our ventilator weaning, and other side effects that it has, or the bad effects that it has, not the side effects. And who else than Dr. Saikat Mitra, who keeps intriguing us during in the group also about various asynchrony graphs and making us trigger our brain to interpret it. So Dr. Saikat is going to take us from basics of ventilator asynchrony to what to do at the bedside and even the advanced levels of it. So if we can't finish it in today's webinar, we will have a second session too sometime soon. So Dr. Saikat has done his fellowship in cardiothoracic ICU and ECMO from Singapore. He's actually from India. He finished his FNB critical care medicine from India in Delhi and also has done his EDIC. Now he's an advanced trainee in the ICU at Barwan Health in Australia. So I'll just pass it on to Saikat to take it forward.
Thanks, madam, for the nice introduction. I will try to share my screen first.
So before we begin, also one point, if you have any questions, you can put it in the chat box. If you think the question is too big enough that you can't explain it in a chat box, we will let you in to speak. So just raise your hand in that aspect. Okay. And also Dr. Saikat will be sharing some polls during this whole process. So try to attempt the polls to have it a more interactive session.
Is my screen, am I sharing my screen?
Yes.
Are you able to see?
Yeah, we are able to see your complete screen.
Okay. So can you see the screen? I'm not sure.
We can see your complete screen, Dr. Saikat.
Okay. So basically, as ma'am mentioned that our topic of discussion is ventilator asynchrony. I will try to keep it simplified as much as possible. And as we move forward, there will be a number of polls. It would be great if the esteemed attendees can poll, and whatever happens here stays here, and it's all anonymous polls. So to start with, can everyone please scan into the Mentimeter, please? I'll give a minute.
So we can't see a QR code or anything to scan in.
Can you see now?
No.
Now?
No, not visible. We can just see your desktop screen where we can see the Zoom screen.
Can't you see my slides?
No.
Just a second, what happened?
Maybe you can stop sharing and share again.
Are you able to see now?
Yes, we are able to see. Now the
Are you able to?
Yeah, now we can see the slides. Maybe you can go on a full mode.
And are you able to see the QR code?
Yes, we can see.
Okay, sorry. So that is the first slide, and this is a slide. If everyone can please scan the QR code. So whatever happens here stays here is all anonymous poll. And okay, so the purpose of our today's session is not this session is for taxonomy based classification or not going deep into the evidence, because I know the more evidence I speak, the session will be more and more bored. But this is more about recognize the asynchrony at the bedside, understanding the physiology, and have a structured approach to fix it in real time. And most important, we should treat the patient, not the machine. It's more about putting everything in context to approach these asynchronies at the bedside. So to start with, can I please ask our attendees to poll where they stand in identify asynchrony at the bedside? I'll give a minute. I'm hopeful by the end of this session, people would be able to confidently fix it. Okay, so I will start with simple basic thing from the ventilator curve. So there are phase variables and that include three parts: the trigger, that include the flow, pressure, and time. B is the limit, which regulate the gas flow during each breath, which can be flow limited or pressure limited, or the cycle, what causes the breath to end, which could be again flow, volume, time, and pressure. Now again, I'm not using the taxonomy classification, and I don't personally use a taxonomy classification, but whoever uses the taxonomy classification, that also another approach to deal these scenarios at a bedside. Now I'll straight away go into today's topic of discussion is a patient ventilator asynchronous. There are many causes of patient ventilator asynchrony. I will come across one by one. Now, types. So types can be three types. That can be again based upon the cycling of the ventilator. So whether it depends on expiratory, inspiratory cycling, whether it depends on the inspiratory phase, or whether it depends from inspiratory to expiratory cycling. So commonly the inspiratory cycling that is this part is called trigger asynchronous. If something is happening here, that is called flow asynchronous. If something is happening in this part, that is the cycle asynchronous. So I will try to go deeper into each of them one by one. Now this is more about the poll time. And I'm putting up the poll. This is the screen. So here comes the first poll. Yeah. So I'll go back to the screen again. This is a asynchrony curve. I will request more and more attendees to try to attend the polls. I'll give a minute to the people to do the pollings. Okay. For essence of time, I will move forward. I agree with majority. This is delayed triggering. And as you understand, this is about trigger asynchrony. To start with the basic thing, there are two type of triggering that we commonly use in our day-to-day practice. That is the pressure triggering and the flow triggering. So from the pressure triggering curve, we can see there is a negative deflection in the pressure curve, which denote this is a pressure trigger. And if it's a flow trigger, there will be slightly positive deflection in the flow curve. Now, there are many difference between the pressure trigger and the flow trigger. So in the pressure trigger, as you can see, if the PEEP is set at 8, and if we set the pressure trigger as -2, the patient has to take a breath up to 6 -2, like 6 of PEEP to trigger the breath. Again, if the patient is taking ineffective breathing efforts like up to -1, then they will not be able to trigger a breath in that instance. Again, if the breath is or the pressure trigger is set too much negative, like -5, in that case, patient has to take a deep breath so that the pressure in the alveoli drops from 8 to 3. In that case, if the patient respiratory effort not that high, they might miss the trigger. Now the flow trigger is better in most of the scenarios, but there are few scenarios where I will come in next few slides where pressure trigger can be better. Now in the flow trigger, I don't know how much justification I've done by drawing this figure. There is a schematic diagram. Now there is always a bias flow, which is a continuous flow flowing in the circuit from the inspiratory circuit to the expiratory circuit. There is a bias flow. It depends from the manufacturer to manufacturer. For here, I have as an arbitrary value I've taken as 5. It can be 3, it can be 4, anything. Now, when we set we set the flow trigger as -2, sorry, not -2, as 2 or 3, then that means when the patient takes a deep breath, this diaphragm goes down, and due to this, some of the flow enters into the patient. When the part of this flow enters into the patient, the remaining flow which goes into the ventilator detects the difference in this bias flow, and that triggers the ventilator to help the patient in initiating a breath. So this is the basic difference between the flow trigger and the pressure trigger. Now coming back to the asynchrony that I have mentioned before, if the delay in the triggering, be it pressure or flow, is more than 100 millisecond, like in this case, that is a case of delayed trigger. And the causes could be many things. One could be patient. I divide always the patient and machine. The patient could be if there is autopip or dynamic hyperinflation that can be seen in a patient with COPD or severe asthma, or if a pressure triggering, which is too negative, being set on the ventilator, then that can cause or contribute to delayed trigger. Now, this is a second asynchrony. This is a graph, and the pole is coming now. I'll go back to the curve again. Feel free to poll. These are all anonymous polls. Okay, so this is classical of ineffective triggering. As you can see, there is also degree of autopip developed. Likely, this patient has got underlying obstructive airway disease. And as you can see, as there is autopip, the patient not able to trigger the breath here. So this is likely ineffective or wasted breathing efforts. And the clue is the patient is developing autopip here. So what are the strategies? Again, I divide into patient and machine, and whenever I'm clueless at the bedside, I go as if patient, I'll go brain, spinal cord, airways, lungs, chest wall, like that. So in this case, the ineffective triggering could be due to decreased neural drive, maybe the brain cause excessive sedation, paralytics, or due to respiratory muscle weakness, or this could be obstructive lung disease contributing to autopip, or the patient, we said the titer volume very high. That's why, and also with the rapid respiratory rate, as the expiration time is very less, they're not able to expire all the volume contributing to autopip. And the other cause is the ventilator, which is an inappropriate trigger setting. these are the corrective measures. So we have to correct one by one. If it is a decreased neural drive, we'll try to reduce the sedation. We'll try to reduce the medication that can contribute to depress CNS, like benzodiazepines, opioids. If it is a respiratory muscle weakness, likely in ICU setting, the critical illness polyneuropathy, that includes optimization of the respiratory muscle, optimization of the respiratory walk-up breathing, and optimizing nutrition, physiotherapy. And for the intrinsic PEEP, what we can do simple basic thing like reducing the respiratory rate, decrease inspiratory time, and address the cause, adequate suctioning, nebulization, and treating any underlying infection. And if the trigger is set very high, we have to increase the trigger sensitivity. That means if the trigger sensitivity in the flow trigger is set at 4, we'll try to drop it to 2. The less means more sensitive, 4 means or higher means less sensitive. Now coming to the third, identify the asynchrony. These are all taken from real life cases, and the poll is coming here. I'll go back to this curve again. However, in this case, I will go with the minority. This is like nobody asks for this red. This is likely auto-triggering. So likely this is a case of cardiac oscillations where you can see like the cardiac rhythm or the cardiac or the heart rate. And if we go to this figure, these are the oscillations we can see here and how to suspect them. We have to match the breath with the ECG or the heart rate and the saturation waveform. If we think is auto-triggered, in every ventilator, there is a maneuver called P occlusion measure at 0.1. We can press the P occlusion measure and we can do multiple time, at least 3 to 4 times. If it is 0, that means the patient is not triggering the breath and the measured respiratory rate is more than the set rate. That gives a clue this is auto-triggering. It's not a real triggered breath. This is one of the way auto-triggering can be detected at the bedside. Yeah, this is another one. And here you have to identify the underlying cause for auto-triggering. And the poll is here. Okay. So this one, what we can see, the in the volume waveform, it is not reaching the baseline. So there is some leak in the circuit. That could be in the tubing itself, that can be the cuff leak, or that can be if the patient has got a chest tube, whether there is a bronchopleural fistula or not. There could be leak in various places along the circuit from machine to the patient. And also the other thing, here we can see in the flow time graph, the inspiratory area is more than the expiratory area. So these two clues give this is likely auto triggering from. So here the auto triggering occurring from leak in the circuit, but we have to find out where is the leak. So there are different causes of auto triggering, and the measures include look for the leak, compare with the bedside ECG and the heart rate and saturation. Here in this case, there are few evidence that the pressure triggering is better than flow triggering, and they can minimize the auto triggering. And here we have to decrease the trigger sensitivity. That means if a patient on flow trigger set at 2, to decrease auto triggering or the unwanted sounds happening, we can go up on the triggering from 2 to 4 or maybe 5. This is next one. Now for this one, so this is asynchrony. So I think I didn't put up the uh, poll. Anyways, so basically this is a reverse or early triggering. How we can identify this? So this is a mandatory ventilator breath. I will come to this, that result in delayed asynchronous diaphragmatic contraction, deeply sedated patient. So that means here the ventilator is itself triggering or causing the diaphragm to contract and triggering the next breath. If it happens over multiple breaths, that is called entrainment. However, if the second breath is very strong, this can lead to double triggering. So here we can see in ideal situation, the curve should go towards the baseline. And here the expiratory waveform should have the elastic component and should reach the baseline. But here, what we can see, there is no triggering by the patient. I'll come to this from the previous curve. The breath continues. That breath initiated by ventilator triggers or causes the diaphragm to contract to initiate another inspiration that is seen as a notch. And when it happens, this continues, the inspiration continues, as you can see here, and that causes these positive deflection in the expiratory waveform. This is positive as because this is the positive side and this is the negative side. So if we go back to the picture here, the one that I've shared, this yellow one shows all a machine triggered breath. This is taken from the trigger ventilator. Usually if the patient triggering the breath, there will be a small lung sign, which is not here. Now the red arrow shows that this ventilator triggered breath has caused contraction of the diaphragm, producing a notch. And as the inspiration is continuing, starting the patient inspiration is continuing from here, this has caused in the expiratory phase a positive deflection, which is also due to this initiation of diaphragmatic contraction. Now, how to know this is the contraction of the diaphragm? This corresponds with this scoop pattern at the end of the pressure waveform, which is a negative deflection. That means the inspiration is continuing. Having said that, the other name of the reverse triggering is the early triggering. Hope I am clear this part. If you think I need to stop, please you can let me know by unmuting yourself. I can go back and again clarify. Now, this is an ideal situation. One of the situations we commonly see double triggering associated with reverse triggering. As you can see, there is no patient triggered breath. There is no lung sign. But as this breath has continued, there is a diaphragm contraction and the ventilator thinks this is a patient-initiated breath, and daily, as it is strong enough, the breath continues and leads to double triggering. So how to deal this situation in real life? So this mainly happen where we maintain draw score of -4 to -5. That means deeply sedated and paralyzed patient. So in that instance, it's better to come off the sedation or pull back on the sedative drugs. Try to wake up the patient. If required, we can change to pressure support once the patient is more and more light. And even after all this, if we are not able to fix this reverse triggering, the ultimate thing is that we should stop uh, having this double triggering breath, as we know that can lead to ventilator-induced lung injury. And in that case, we should go back to the full control mode of ventilation and start paralysis. That's in the extreme case. But in ideal situation, what happens if the patient is deeply sedated? We try to lighten up the sedation and change from the control mode to the pressure support mode. And sometimes that resolves these asynchronies at the bedside. So this is a nutshell about the expiratory inspiratory cycle or the trigger as asynchronies. Now going to the next one. This is a figure. I don't know why my things are not coming. Just give me 1 second. Anyways, sorry for this. I don't know why my poll's not coming. So this asynchrony, this is the inspiratory asynchrony, where we can see that the scooping of the inspiratory part of the pressure waveform. So this is the flow asynchrony, or what we call, the new terminology is a walk shifting. So in this case, the causes are different: inadequate flow, or the patient has got increased respiratory drive. That could be due to because of the underlying pathological process, or the patient is in pain, they're taking deep breath, or maybe fever itself. So if it's in the volume control mode, I'm not going into the taxonomical classification. This include increasing the flow or sometimes switching to the pressure mode, because in that case, the flow varies with patient effort. If the patient is on pressure support, sometimes we can reduce the rise time to deliver the breath early, and that can sometime resolve these work shifting. And of course, we should treat the patient, the underlying cause, the underlying pathology. That could be pain, that could be fever, that could be underlying pneumonia contributing to this increased respiratory effort. Yeah, so this is the next one. And okay. Yep. I can go back to the the curve again. This is a curve. Okay. So unfortunately, as we know, this I will go with the minority and this will be none of the above. Now, as you can understand, I'm going into the next type of asynchrony, that is the inspiratory and expiratory cycling. This is early cycling. How to know that? So the previous graph, I have put up that curve here again. So this here, now as you know, the inspiration expiration is color coded in different ventilator, and it depends on ventilator to ventilator. In this ventilator, the pink initial part shows that these are patient triggered breaths. And likely this could be the microwave ventilator, if I'm not wrong. So this one shows that the patient is triggering the breath. And I put the PMAS or the pre-esophageal monitoring here in ideal situation. As you can see, as the patient is continuing the inspiration, this curve goes up and touching the baseline. And this thing corresponds with the dip after the pressure waveform. This happens because the patient inspiratory time is more than the ventilator inspiratory time. This is early cycling or premature cycling. That happens as mentioned if the ventilator I time is set less than the patient I time, or there is a low tidal volume in the volume control ventilation set. If we put a VCB mode, as we know, the flow uh, the flow formula is the tidal volume divided by inspiratory time. And if we rearrange this, so if we want to increase the ventilator I time in volume control mode, either we have to increase the tidal volume or we have to decrease the flow. Similarly, in the pressure modes, we can set the I time depending on the early cycling, monitoring the curve at the bedside. We can go up on the I time slowly and see if this asynchrony is resolving by its own or not. So this curve, or this is again taken from the chest. I think this was published last year, which shows that different type of early cycling happening in different ventilator mode, and essentially the same thing what I have explained just before. This is another real patient. Identify the asynchrony. Might be a bit tricky. So this is a curve. I will give bit of time to the attendees to think on this before I explain this. Again, these all are taken from real life scenarios. Okay, so this is early cycling and active expiration. So again, I try to put the esophageal the waveform here. As you can see, the patient is continuing the inspiration. This, if we draw a line from here, we can see that the TI is almost matching here, but the patient inspiration is continuing, which means the ventilator TI is shorter than the patient TI. As the patient is continuing the inspiration, this scope, the negative or the positive deflection, the expiratory waveform corresponds to the negative deflection, the pressure waveform. In ideal situation, the flow curve should have reached the baseline like this, the red dotted line. This part shows that there is a muscle, the P mass or the active muscular activity during the inspiration. In the expiratory flow curve, ideally in ideal situation, this should have reached from here to here. But this part, the positive deflection from below the yellow dotted line shows that there is some active expiration because this more negative deflection, as this part is more negative below the waveform, below the baseline during the expiration, there are positive bumps in the pressure waveform, in the corresponding waveform. That means along with the early cycling, the patient is trying to do expiration actively. In normal cases, the expiration should be passive. So this makes me wonder whether the patient has got underlying obstructive lung disease or not. Mainly in patient with COPD or asthma, they try to do active expiration. So as this has been taken from one of the real life scenarios, I know the patient has got very underlying, very moderate to severe COPD. And as you know, the early cycling, by decreasing the expiratory trigger sensitivity, I was able to reduce these early cycling and make it almost normal, but sometimes it's not possible to perfect normal in real life. Now, this is another example where we can see there is early cycling happening with double triggering. So how to know that this breath, as I mentioned, is a trigger ventilator. The patient is triggering the breath. As a result, as the patient inspiration is continuing this part, as the ventilator TI set is less than the patient intrinsic I time, that has triggered the next breath, leading to double triggering. So double triggering happens in two instances. If the patient is deeply sedated, there is a reverse triggering, and that causes double triggering. And the other instance, patient is triggering the breath, but the patient TI is more than the ventilator TI, that patient TI continues and it triggers the second breath. So there are two instances where we can see double triggering in our day-to-day practice. Okay, now identify the asynchrony. So this is the one coming here. I'll go back to the waveform again. I think in this case, I'll go with majority. Well done. So yes, this is late cycling or delayed cycling. So here it is opposite of early cycling. Here the ventilator TI is more than the patient's intrinsic inspiratory time. Uh, so here we can see the white one is a normal machine's inspiratory time, the white box, and the red box shows patient's intrinsic inspiratory time. As you can see, the patient inspiratory time is less than the ventilator inspiratory time. There is a phase which is a zero flow period, which is actually wasted. And during this phase, the patient is actually expiring, and that is causing this pressure overshoot due to the expiratory muscle contraction. So if there is a pressure overshoot at the end, that can with zero flow period, and if we draw a line from the end of the flow where the patient is ending inspiration, we can clearly see the patient TI is less than the ventilator TI. We call this type of asynchrony as late cycling. So again, this is just opposite of early cycling. As mentioned in volume control mode, we try to decrease the tidal volume or increase flow. If you can remember the formula of the flow and the I time, and in the pressure mode, we'll just do exactly the opposite, come down on the I time. This is another one, again taken from real life case. If we see, this is again early cycling. I'm just draw the line. This is a ventilator TI, this part, and this is a patient TI. The patient has finished his inspiration here and started expiration. The trigger ventilator has got expiratory valve, and that is causing these small bleeps uh, along the baseline. I have drawn the patient inspiratory effort as well. So if you can see, there is mild overshoot can be seen here due to the active expiration. As the trigger ventilator has got these active the expiratory valve, the pressure overshoot is not that much prominent. So given the patient TI is less than the ventilator TI, this is one of the example of late cycling. Now identify this as synchrony. These could be a bit confusing and tricky as well. So here comes a poll. So this is a cough. And this type of waveform we commonly see at bedside.
Second, there's a request to show the asynchrony slide a bit longer before going to the poll.
Okay, no worries. But are you able to see my polls even if I'm showing the asynchrony slide?
No, we can't, because once we
Okay,
need to change the slide, the screen goes black.
okay, okay. I will go back and forth then. I'll give some more time. because there are only few slides left, so I have enough time. Yeah, I know. This type of asynchronous take time to solve. Even when this type of waveform I see at the bedside, I keep on scratching my head. I don't know what's happening. And that's very normal. Okay, so this has got everything. In ideal situation, the pressure waveform should be like this, but we can see there is scooping of the initial part of the pressure waveform, likely due to excessive P mass. That is work shifting. Now, the inspiration is finished here, but what about this rising part? This is due to contraction of the expiratory muscle. That is why this is late cycling. The patient inspiration has already stopped, as mentioned, but here, due to the contraction of the expiratory muscle, we can see this rise in the pressure, followed by the dip, and followed by the next inspiratory effort that leads to this ineffective trigger. Because here, due to late cycling, the ventilator is in the expiratory phase, but it is opposing with patient's inspiratory effort. So that means late cycling is associated with ineffective efforts. Early cycling is associated with double triggering. Reverse cycling is associated with reverse triggering. We will not be seeing any ineffective efforts with early cycling or reverse cycling, reverse triggering. Hope this part is clear. I know this is a bit tricky one. Let's go to the next one. Identify the asynchrony. I'll go to the pole and I'll again come back to this slide. So this is the pole and now this is a slide. I'll give a minute for people to think what's going on. Again, as you can see, this is taken from real life case. Okay, we'll hold here for another 30 seconds before I go to the polling again. Okay. This is a slide again. This is Okay, this is lead cycling. Always what I do in the bedside, I freeze the waveform. As you can see, I freeze the waveform here. This is a lung sign. This is a lung sign. The patient is triggering the breath. That rules out this is not reverse triggering. Now I bring the cursor here. See whether the patient TI is matching with the ventilator TI or not. Clearly, it's not matching. And there is a pressure overshoot. So this is lead cycling. Now, people might be confused with this part. Drager ventilator has got active exhalation valve. So that means during this phase, as you can see in the schematic diagram on the right, it is the expiration that is happening and the ventilator has opened the exhalation valve. So this is lead cycling. Again, please don't get confused. This is not early cycling. Whenever you're confused, freeze, bring the cursor at the end of the patient or flow TI and see whether it is matching or not. Now identify this asynchrony. This is the last slide. I will give some more time to think before I go to the polling. And people might find this one really interesting. Okay, I'll come back to the waveform again. So these are the options. And this is the waveform. Okay, so this is taken from this nice article published last year in the Journal of Mechanical Ventilation. This is a Batman sign. Okay, and they named it because there are two type of asynchronies. One is a flow asynchrony and one is a delayed cycling. So it looked like consecutive waveforms looking like a Batman. So just they name it as Batman sign. Here I finish my slides. If any questions, happy to answer, but
Yes. So I think you can stop your screen share. Maybe you can share if required. Okay. So there are some questions which have been asked in the chat box. It was definitely an informative session, going very slow and informatively explaining every concept in detail. First, I will take a question which came towards the end, which asked, can you repeat the correlations which you mentioned? This is from Abhilash.
Okay, so correlations I mentioned that if it is a reverse triggering, there will be double triggering. There can be double triggering, may or may not be. If there is early cycling, as the inspiratory effort is more, is ongoing, there can be again double triggering. If it is a late cycling, it is usually the wasted breaths or the ineffective triggering. You are muted.
Sorry. I'm so sorry. So we have Tofik from Solo who's saying, how can flow and pressure waveforms be used to identify different forms of ventilator asynchrony?
I find this question a bit vague. If it can be more precise, so I didn't get what he actually meant by different type of asynchronous, because let me put in this way. Okay, there are two modes. One is the volume control. I'm not going into the taxonomical classification. Volume mode and the pressure mode. If patient is on volume control mode, we know in volume mode the flow waveform is constant. In that case, we have to look into the pressure waveform to think about asynchronous, and it is just opposite in the pressure control mode. Like in pressure control mode, the pressure is constant and the flow varies. So if any asynchrony happens, it will be in the flow waveform. I am not sure if I have answered correctly or not, if this is what he wants to know.
So are there any specific asynchronies that you expect in a mode, like a volume control mode will have these asynchronies, or all can happen in every mode?
All can happen in every mode. Like all can happen in every mode. There is no exception. I don't know, but anyways, if anybody knows, feel free to comment.
So Tawfiq, if you are not okay with the answer, you may always raise your hand. I can allow you to speak. Then we have Arfianda from Indonesia again. She's saying thank you for the lecture. And she's saying, how do you distinguish between delayed cycling and expiratory asynchrony on the waveforms, particularly in obstructive lung disease?
So expiratory asynchrony means auto flow or ineffective triggers, ineffective efforts.
I think it should be auto flow because she's talking
Not auto flow, auto PEEP.
auto PPS, intrinsic.
Ah, okay. So I didn't include auto PEEP here because it's all about asynchronous. But if you people can remember, I did share a slide where there is an ineffective effort and the flow waveform is not touching the baseline. So if it is, so in every patient, every type of asynchronous can happen. So more commonly in a patient with COPD or obstructive lung disease, they do have this dynamic hyperinflation that can lead to ineffective trigger. We can see that the flow waveform is touching the baseline but not triggering a breath, and also the flow waveform is not reaching the baseline at the end. That means the patient expiration time is more than the ventilator expiratory time.
So there's another question which is commented on your waveform. I unfortunately cannot point to which waveform was this question put. But Rio is asking that on the waveform which you had shown, the patient was taking two breaths back to back. And how does this lead to volume trauma? I mean, doesn't it lead to volume trauma?
Yeah, so what I think that Andy is trying to ask about the double triggering. So if when you are at the bedside, if this is happening, always look at the expiratory tidal volume. So invariably, if it's a double triggering happening, if the set volume is for example, is 450, and it is showing 1000 with that breath, that excessive tidal volume is causing the ventilator-induced lung injury. That's how the double triggering leads to volume trauma. So we have to be careful. Double triggering is not good for the patient. We have to be careful. If double triggering happening, we have to troubleshoot at the bedside. One, always think about the patient. Machine is only a part. Treat the patient first. Whatever I have mentioned in my slides, they look attractive, but in real life, treat the patient, treat the underlying cause.
Right.
If you treat it, most of the asynchronies will resolve by its own. And that's very true.
So next question is comparing the two types of asynchrony which happens during cycling. That is, it's asked you to compare premature cycling with delayed cycling. And in that mechanism, in the waveform appearance, and how will you manage? So this is from Avalianto from Indonesia again.
I think I have mentioned in my slide, like I'm sure that this video will be recorded. It would be
Yes.
great once recorded to go back and see the slides. I'm not putting up my slides again. So basically, the ventilator, the early cycling and late cycling are just exactly opposite to each other. So in early cycling, the ventilator is cycling early than the patient's own intrinsic TI. So the patient's inspired time or the inspiration is ongoing. So in this case, we have to in both the cases, we have to match the ventilator TI with the patient TI. So in early cycling, we have to increase the ventilator TI, while in late cycling, we have to decrease the ventilator TI to match patient's inspiratory effort.
Right. Right. Then we have Dr. Mukti, who's saying an ARDS patient, how can lung protective ventilation strategies influence the risk of asynchrony?
It's a very good question. Everyone is asking very good question, but I think it depends on the type of asynchrony. So in lung protective ventilation, when patient is in severe ARDS, they're deeply sedated. If you have read the Rose trial, they have shown in deeply paralyzed patient, there is no benefit. That is due to reverse triggering. So in severe ARDS patient who are deeply sedated, mostly, we do paralysis, we give high dose of sedation. They have risks of reverse triggering that can lead to double triggering, and that can lead to more and more ventilator lung induced injury. Again, if the patient is recovering from ARDS, when you are trying to win, they can have different type of asynchronies, and that can again lead to increase length of ICU stay, increase ventilator dependency, and increase mortality as well.
The next question is from Dr. Ismail, a very interesting question. So when you have a patient of severe COPD and you're trying to wean this patient, how are you going to differentiate between ineffective triggering, whether it is happening due to neuromuscular weakness or whether it is happening due to high intrinsic PEEP or auto PEEP? And what will be your step-by-step strategy to optimize the trigger sensitivity in this case?
Right. Okay. So first of all, we know the pathology is COPD patient. What I'll be doing, it depends on which mode the patient is on. Is it in a volume control mode or in a supportive mode? Whatever mode it is, I will try to find out if the patient is not triggering any breath. I will try to find out the auto PEEP. In trigger ventilator, what we check the trapped volume. So there is a maneuver when we do the intrinsic PEEP if the patient is not taking any breath or deeply sedated or paralyzed, not paralyzed, deeply sedated -5. I check the intrinsic PEEP and check the trapped volume. Invariably, in all COPD patient, whatever maneuver we try, whatever strategies we try, there will be some amount of auto PEEP, and we have to accept that. Now it depends if that amount of auto PEEP, I can talk about this in a different video, how to manage the auto PEEP at the bedside. Now, depending on the severity of the auto PEEP, we have to decide whether that is causing more trouble to the patient or not. Now, if I can see from the ventilator form that is causing ineffective triggers, I will try to optimize patient first before I touch ventilators. Though I would say do it simultaneously. Treat the reversible causes. If excessive secretion they have, try to suction. If the patient is still wheezy, patient needs some more time, give nebulization, give steroids, treat the underlying infection. If still that is not resolving the issue, go to the ventilator. I divide patient and machine. In the ventilator, depending on the mode, if the volume is high, I'll come down on the thyroid volume. I'll decrease the respiratory rate to increase the expiratory time. There is another thing that can be done in the trigger ventilator is to calculate the time constant. I calculate the time constant. If the time constant, if I know is 2 seconds, roughly 3 to 4 times will be the expiratory time. I try to set the expiratory time according to that time constant. Even doing all this, there will be some amount of auto PEEP in the COPD, but it's more important to see that is causing harm to the patient or not. I don't know if that answers the question or not, but I can talk about this in a different webinar or different talk.
So can I add to this if you don't mind?
Yeah, absolutely.
So I think his question was when you're weaning the patient, how are you going to differentiate that the patient is not generating enough tidal volumes or having ineffective triggers, is what he meant. Is that due to autopeep or is it due to neuromuscular weakness? That is the specific question that he asked.
Right. So yes, right. Very good question. I missed that part. I was thinking of answering this as well. If the patient is on pressure support ventilation, I don't know about autopip. What I can know from the waveform, is it reaching the baseline or not? One. Second, calculate occlusion pressure 0.1. If it is due to ineffective, or if the value is, I try to keep the value between -1 to -3, and try to calculate multiple times over different breath, because they can vary, and take the average of 3 to 4 breaths. If the value comes out to be -5, that means the patient is doing much work. I have to play with the pressure support in that case. But if the value is 0, less than or towards a positive value, like 0 to -1, that means I'm giving more support to the patient, and that can be due to more sedative medication that we have used to the COPD patient, that is causing the decreased neural drive. Then I will try to address those issues. So P0.1 is very helpful at the bedside to differentiate these two. I find it useful, but I'm sure there are many ways to say this. There is another thing called expiratory flow limitation. I'm not talking about that. We can do that. If we do in the bedside, if the flow volume curve is not reaching the baseline, by that we know that the equal pressure point is shifting. I can talk about that in a different session, but this is another way to detect at the bedside as well. You are muted, ma'am.
I'm so sorry. So next question is from Dr. Jessica. She's asking, in a patient of pulmonary contusions, a patient who has thoracic injury, is double triggering always harmful? Or do you think it can sometimes be a physiological response to unmet ventilatory demand?
Now, is a good question. Now, what is meant by unmet ventilatory demand? By itself, that means either early cycling or late cycling. Double triggering, if it is contributing to excess breath, that is always harmful to the patient. I will try to avoid double triggering. I have not seen any patient with double triggering the tidal volume is low or normal. It's always high.
So in double triggering, this question, I'm just mixing up questions so that they can go in same order and we can take one topic at a time. So this is from Dr. Maratus. Sorry if I'm pronouncing it wrong. In patients who are showing double triggering, how you are going to clinically differentiate whether he's having air hunger and needs more flow or volume versus a patient who simply has an inappropriately short inspiratory time?
No, I think the question framed was wrong. Air hunger will be defined by walk shifting, not by double triggering. That is the first understanding. That is my understanding as well. If the patient is air hunger, there will be flow shifting, or sorry, walk shifting, or what I used to call previously as flow starvation. What was the second part? Sorry, I missed that.
So
Skip my mind.
whether it is going to be air hunger or is it a shorter inspiratory time, which is the reason for the double trigger?
So shorter inspiratory time, that means early cycling, then I have to find out is it early cycling or not. Air hunger, if there is associated air hunger, then we will be seeing in the curve there is a walk shifting as well. That can be one possibility, but in that case, there will be early cycling as well. Like one of the cases I shared, that there is a walk shifting, late cycling, and ineffective effort. Similarly, if we freeze our form, we'll see that there is a walk shifting, that like there is a ineffective or low flow that is contributing to increase inspiratory time compared to the ventilation, leading to double triggering.
So air hunger can lead to double triggering is what we can say. It's
If
one
it
of
is early cycling, if there is early cycling,
yes.
air
So
hunger itself will be shown as a flow starvation
yeah.
or the
So
walk
air
shifting
hunger,
will be shown.
sometimes you require a huge tidal volume, which you may not deliver in the time, inspiratory time, which has been set. So though the inspiratory time is adequate, it is early for the patient, which can lead to double triggering as well. So there's no way you can differentiate rather than looking at the patient, like is he being restless because of the excess air, minute ventilation that he needs. And sometimes it helps in looking at the patient and deciding this thing, I would say.
Yeah. In this case, I can measure the pre-occlusion pressure. It
Right.
will be very, very negative. Do it.
Right. Okay. So, next question is from Akila from Indonesia again. Which is the most common cause of ventilator patient asynchrony in your clinical practice that you have seen?
No, it's multiple. There is no single one.
Okay. So in my case, I would say a lot of pain related factors are what causes, or delirium which causes asynchrony. Okay. What waveform?
It's multifaceted.
Yeah. What waveform changes which is a waveform that you usually prefer to see, which will help to identify delayed cycling, whether it is pressure time, flow time, or volume time.
Volume time, forget about flow volume time. As I have answered one of the questions before, if it is a volume control mode, so simple volume control mode, in that case, the flow is constant. We have to look into the pressure waveform. If the volume control mode is in rigor, there is auto flow. When you turn it on, it becomes PRVC, is like adaptive mode. In that case, we will go into the flow because the pressure become limited. Similarly, in pressure control mode, as the pressure is limited or is constant, we have to look into the flow.
Right.
Volume, like if double triggering happening, you can see that things volume is too high, that's all. But I personally don't know, maybe pardon my ignorance, whether by seeing the volume I can identify the asynchrony or not. I don't know the right answer. Leak and all I can, like auto triggering, yes. But for delayed and late cycling, I'll be stick to pressure and flow.
So Ruri from Indonesia is now asking what difference can be seen between normal cycling and late cycling waveforms in the ventilator.
Oh, again, I have to pick up those slides again. I would request that once this recording is available, go through my waveforms. So basically, you have to find out normal cycling is normal cycling, nothing to worry about. It's everything is normal. If it is a late cycling, freeze the waveform, bring the cursor and see whether the patient TI is less than the ventilator TI or not, depending on the mode. That's one of the easy way, but again, every patient teaches you something.
Right. So when we were talking about COPD, is it okay to calculate the auto peep in addition to looking at the waveform?
Yeah, if the patient is on volume control, deeply sedated, not triggering breath, yes, you should. You should calculate the auto PEEP. You should check the intrinsic PEEP. You should check the trap volume. Yes, absolutely. Because that will help to set the extrinsic PEEP as well.
So this is another interesting question from Hidayah from Indonesia again. The question is, in patients who have increased respiratory drive, as in most of our patients with sepsis or metabolic acidosis, how do you determine what level of ventilator asynchrony would you accept? Or what is your point where you will decide to escalate deep sedation or even give neuromuscular blockade? Because you have to balance between patient self-inflicted lung injury versus avoiding the diaphragmatic dysfunction. So which is your point where you want to accept the asynchrony and start giving sedation so that it can worsen the dysfunction?
So this is all theoretical. There is something called asynchrony index. If I can remember, I forgot the formula. If it is more than 10%, then we have to treat. If it is less than 10%, accept. There are evidence, but again, I have to go through the formula. You can Google the formula. Sorry, I can't remember the formula.
Okay. Can you explain the correlation once again? Is a request from NRJ.
Okay. So correlation is reverse triggering is there. So double triggering is there. It can be associated with reverse triggering or early cycle. Ineffective effort is associated with late cycle.
Okay.
dt is equal to RT or EC, short form, or ineffective effort is equal to lead cycle. I don't know how to remember, but if you keep on practicing, it will come from your spinal level.
So it was a very informative session, Dr. Saikat, and very interesting. A lot of people, I am sure, got all their doubts cleared. We have recorded this and we will be uploading on our YouTube channel, CritiLearn YouTube channel. You can follow that, or I will also be sending this link on our CritiLearn WhatsApp group. I have shared the link of this WhatsApp group in the chat. All of you can just click on the link to join our WhatsApp group if you all are willing to join. And it was a very informative session, and we are looking forward to having more sessions with Dr. Saikat on CritiLearn, hopefully, if he gives us enough time. So thank you so much for joining, Dr. Saikat.
Thank you. Thanks for the opportunity. But of course, hopeful this was helpful to every one of you. And please go through the recording again. If any doubt, please put forward your doubts in the CritiLearn group. If you are there in the group, we will be happy to address your concerns or any queries.
Thank you, everyone, and hope to see you all soon. Oh, there's one more question. What WhatsApp group? I'll share the link here also. Just a second.
I might leave.
Yeah. So
Yeah.
I've
Thanks
shared
all.
the answer. Yeah. Thank you. Thank you, Dr. Saikat. I'll also look. Thank you. So the group link is on in the chat box, and it is also there in the Q&A section now. So thank you so much for joining. Bye. Thank you, Irene.